honestly wasn't thinking about anything that personal. I was actually thinking about that quote, "The personal is political," the slogan associated with feminism in the 1960s and 70s, and the linkage of our experience as individuals with how we organise society. And this has always been really intellectually interesting to me. But, you know, we never know what's going to happen in life, do we? So, the Monday of Family Day weekend in February, life was pretty good for me. So we just had the Premier's announcement that the new St Paul's was going ahead. A friend of mine was over from the UK, and so we were up in Whistler for the weekend. And I was thinking, how lucky am I? I have a job that I love. I live an hour and a half from a world-class ski resort. I made friends with people who live there. I'm able to afford to go there for the weekend, and the sun is shining. And then, for half a second, I leant the wrong way and caught the wrong edge of my board. So this is the next picture of me. This is St Paul's Emergency Resource Department. So, long story short, basically I had a concussion. It's called a mild concussion. I think that mild is really unhelpful adjective there. It didn't feel mild. There was some concern about my spinal cord, which was absolutely fine. I had really lovely care, and I'm perfectly fine again now. But the experience made me think a lot, of course, about compassion, what it's like to be a patient, some technical issues about access to complex diagnostics, and made me think about how your brain is actually quite important. Never thought that before. But for the purposes of this talk about social justice, I wanted to talk about two things, and they are power and judgment. So I realised how much power I have in my everyday life. I have money, and money can solve a number of problems. But also I'm educated, I'm reasonably articulate, I can fight my corner, and I've got some social skills that I can be nice to people, and I'm reasonably good, not perfect, but reasonably good at getting people on my side. And none of this helps when you're uncontrollably vomiting in the ED admission area. It's a very levelling experience, and you're not a chief exec there, you're just a person that needs help, with no power. And then I want to talk about judgment. So no one judged my lifestyle choices or talked about risky behaviour. There's one exception actually. One of the surgeons did point out that apparently there's some published data about very high accident rates in snowboarders over 50 years old. Hello? Over 50? Yeah. His operating time, so gone. But weirdly, to me, no one suggested to me that treating me would encourage or condone my risky behaviour. No one suggested that I brought it on myself. And we need to remember that this is not how we treat other behaviour that we consider risky. So, bizarrely, there was serious discussion in the UK, Canada is more sensible, as to whether providing a vaccine against cervical cancer might encourage risky behaviour amongst teenage girls. It's always the girls, isn't it? We never worry about the boys. But spoiler alert, it doesn't. I'm going to talk about PrEP later, and of course my whole talk is partly a warm-up for Dr. Montaner. It's clearly PrEP is being a prophylactic drug that reduces your chance of getting HIV. And one of the debates about this is, does it encourage sexual risk-taking? And I'll talk a bit more about how we've judged people who are ill over the years. But I was very conscious that my particular form of risky behaviour was not judged. In fact, it was understood. I was spoken to kindly about wearing a helmet, which I was instantly, and when I could get back to the mountains. And no one suggested that it was all in my head, although clearly it was all in my head. And no one judged that except for myself. Of course, one thing that never crossed my mind in that whole experience was having to get my credit card out. And that's one of the many great things that the UK and Canada have got in common, that we believe that healthcare is a right, not a privilege. And one of my most powerful memories of Great Ormond Street, which is the National Children's Hospital for the UK, where I used to work, was seeing the children of some of the richest people in the world, from Saudi Arabia and Kuwait, families who had paid privately to get their children what they felt was the best care in they were being cared for next to the children of refugees, people who had fled to England with nothing and still had nothing, or very little. And I was reminded of this as well by a St Paul's nurse at our recent Long Service Award event, who told me she loved her job in the intensive care unit because some days she looked after patients who were homeless and some days patients who were extremely wealthy, and she treated them all the same, just as people. And so we rightly feel proud of this approach to healthcare, and the proximity here in Vancouver of a different approach, with 50 kilometres south of here, reminds us not to take this for granted. But I do worry about this making us complacent, that it's kind of like feeling good about yourself for not being a mass murderer. We kind of need to set the bar a bit higher, I think. And so if you would think that healthcare free at the point of delivery means that we should all have the same healthy lives, and clearly that's not actually the case. That outcomes and experience in healthcare are completely different depending on your income, gender, ethnicity, many other factors. So I could give you a million statistics, but in brief, in Canada, you're likely to live 11 fewer healthy lives if you have a high school education, as opposed to if you're a graduate. Your baby is 1.5 more times more likely to die if you live in a low-income area of Canada. And this graph, which it just shows your risk of suicide. So you don't have to read the numbers, but basically, if you're male and poor, you are 5 times more likely to choose to end your own life than if you're female and rich. And all of this is from 2018 in terms of health inequalities in Canada. And it makes me think of this cartoon. If the privatised healthcare system was on the left, should we feel brave for providing an equal service if the outcome is the right? And I think, personally, we have to do better if we believe in social justice. So, social justice traditionally defined as equal access to wealth, opportunities and privileges. I like the upper definition around fair and just relations. And I know that concept of the importance of relations is so important in both the Catholic tradition and the First Nations tradition, and something which I know this conference has spoken quite a bit about. So this is great. This, I think, is what we should be aspiring to, but our earlier data shows that we're failing, frankly. And why is this when we strive to provide healthcare in an equal way? And personally, I think we've kind of always accepted that that's just how it is. And if we look at the history of how we've seen ill health and healthcare, we can understand some of that because we've gone through a number of different perspectives. So historically, illness was often seen as a punishment for sin. This is a group of patients with leprosy in India. Historically, it was believed that leprosy was a moral consequence, and it was believed that people with leprosy were being punished by God for some moral failing. British India enacted the Leprosy Act, which institutionalised anyone affected and segregated them by sex to prevent reproduction. But this act was only repealed in 1983, and as a British person I have to acknowledge the damage which my forefathers mostly, have done on the world, and that's just one example. I think more recently, ill health was seen as a consequence often of bad personal decisions. So HIV and the reluctance of governments to fund PrEP is a good example of this. You can see that's a UK popular media view of the situation. But equally, there are lots of other examples. In the UK, over half the population feel that the National Health Service should not fund treatment if the illness was as a consequence of smoking. 85% of people in the UK in a survey agreed with the statement that, quote, alcoholics should pay for their own treatment. It's a real pleasure to me to work in British Columbia, where, to take the last two examples, PrEP is funded, and that's in large part thanks to the policy lobbying of the CFE, and we have a large Department of Addiction Medicine who are absolutely treating addiction as a disease, not a moral failing or a bad personal choice. But I think we're not yet perfect in how we think about ill health. And finally, we need to think about the environment. So this is a little girl called Ella. Ella lived 25 yards from the South Circular Road in Lewisham in South East London, and it's one of the busiest roads in London. She died in February 2013 after 3 years of seizures, 27 visits to hospital for asthma attacks. And her death is now being reinvestigated because a new expert report concluded that it was likely that unlawful levels of air pollution contributed to her fatal asthma attack. To make the obvious point, rich people don't live 25 yards from the South Circular. We can't segregate health from poverty. And this is not, we need to do better. And much more recently, we've begun to understand the world of epigenetics. So we've known for ages that your genes have a big impact on your health. But increasingly we've understood that whilst your genes are fixed, how they're expressed depends on life experiences. And this is called epigenetics, the chemical changes to your DNA that prevent or enhance the reading of a sequence. So work that was actually done in Southampton, where I used to work, demonstrated that your chance of having a heart attack in your 50s was influenced by the diet of your mother when she was pregnant with you, and even more amazingly, by her mother's diet, your grandmother's diet, when she was pregnant with your mother. And guess what? This mechanism is just going to magnify all the inequalities that we already have in society. And a very new study from the Philippines specifically identified this. They looked at a cohort of women and showed that there was a really powerful link between their socioeconomic status and the modification of their genes. And so we can now see the mechanism whereby our bodies literally remember the experiences of poverty and deprivation. And more studies are suggesting everything from receiving affection as an infant to childhood trauma can prompt your body to edit your genes, and that will be passed on through generations. So I think we increasingly understand that poverty, deprivation, discrimination, these things can make you ill, and it's no longer good enough for us as health providers to say it's nothing to do with us, and we need to be part of this. So just to make this personal again, here's how the world is getting more uneven. Half the world's wealth is now owned by the richest 1%. And just before we start blaming all the multi-millionaires, the top 1% income earners, which is a tiny bit better, different than the top 1% wealth, but not that different. The top 1% income earners is anyone who earns more than 43,000 Canadian dollars a year. So anyone in this room who earns more than that, that's you and that's me. So given that, how do we get away from equality to liberation? I've got a few thoughts about what we could do about it, because I think this is our responsibility as healthcare leaders. First of all, I just think we need to talk about it. I think we need to be aware, and we need to be conscious about taking off our blinkers as to what impacts for our patients in terms of their health. Secondly, I think we need to be proactive. It's not good enough to just look after people who turn up at our door. Dr. Montaner's going to give a perfect example of that in terms of HIV. I also wanted to shout out to the Foundry, which was set up by psychiatrists who were tired of just looking after young people when they turned up at the emergency department, and said, we need to be more proactive on this. Thirdly, I do think we need to think multi-generationally. It's the only way that we can keep making the world a better place. So the top picture is Southampton. In response to the Southampton studies about epigenetics and early life, Southampton set up Life Lab, which is aimed at teenagers, attempting to adjust behaviour before, particularly the girls, became of childbearing age. And that lab shows statistically significant differences in behaviour from cohorts of children or teenagers who had spent a relatively short time learning about health and their bodies in the hospital, compared to parallel groups who had not done that. And that's, I think, how we can change the next generation's life chances. So you can imagine how excited I was to have a chat to Jeff Redding, the professor here, who is now got funding to set up a similar cohort study on Vancouver Island with the First Nations community, and again see how we can work with that community to put interventions in to change the life chances of future generations. We need to literally remove barriers, and so this is an overdose prevention site now at St Paul's, also in terms of how we set up our services with a basis of cultural safety and humility, because just because we don't see a barrier doesn't mean that there aren't so many barriers to other people accessing and benefiting from the care that we provide. I think we need to think about our staff. One of the biggest impacts that we have as healthcare organisations is actually as employers, not just providers. The impact that we have on social justice in this city and this province is absolutely magnified by how we treat our staff, how we look after them, and how they feel cared for or not cared for. And finally, we need to do research. We need to be driven by need, frustration, and inequality. You know, how society is at the minute is just not good enough, because there's still so much we don't know. And this is Karen Humphreys, who works here, who leads cardiac research lead focused on gender differences, to understand and address why traditionally women's cardiac issues have been missed and misdiagnosed. And finally, I just wanted to bring this back to the overall subject of this conference, spirituality, and to make the argument that social justice is fundamental to this. And this is because I believe spiritual care is impossible if we don't meet each other as individuals with respect and with love. And unless we fight for a more socially just world, we put up too many barriers and we never even meet the people who need our care, or we see them through the prism of our prejudices of poverty and discrimination. So I quote this cartoon a lot. What do you do? No, what do you do for the world? And I just think what a privilege it is in healthcare that what we do and we get paid for, it's also something that we do for the world. I would give everyone here a challenge in that what we do for the world is not just provide healthcare, but fight for social justice, because I think the two things are completely integral to each other. And part of our responsibility is that we need to make the world a more equal place. Thank you very much.
I'll ask Dr. Julio Montaner to come up and speak.
Thank you very much, and it is a pleasure to be here. Following my CEO is a bit of a tall order, both physically and otherwise. Thank you, Fiona, for that presentation. It was actually quite nice and comprehensive. And it really fits very well with what I'm going to try to outline for you, which is the work that we've done for the last 4 decades to address the issues that Fiona was actually highlighting. And I'd like to propose that we can serve as an example of how this can be achieved, not just for HIV, but for other conditions. In fact, if we did it for HIV, we could do it for everything else. So what I'm going to talk about is treatment as prevention as a patient-centered strategy to end HIV and AIDS in British Columbia and in the world. You notice I have an accent. That's not French. It's actually Spanish. I'm originally from Buenos Aires, Argentina. I was happily doing my residency training when I met somebody that I consider phenomenal, Professor Jim Hogg. I was at a conference in Uruguay at the time, and in a random sort of encounter, I engaged in a conversation with Jim Hogg in my usual, I guess, inappropriate spirit, challenging him for some of the statements that he had made and how I would do different experiments to confirm some of his findings. Anyways, that's who I am. And so he took me aside, he sat me down, and after a few moments he said, Dr. Montaner, I mean, you may want to actually come to Canada and pursue some of those experiments with me. And my answer to Jim at the time was, no, sorry, I'm not interested. I want to be a clinician researcher. You're a pathologist. I like to do something meaningful for people and involved in public health. What a piece of work I was. Fiona may say that I'm still armed, but it's okay, it's okay. She'll get used to it. In any case, about an hour after I met Jim Hogg, I ran into very senior professors from Buenos Aires. I mentioned what happened to them. They told me I was nuts and that I had to go back and talk to him and beg him to take me, which I did. By now I was very nervous, and actually he was very gracious, and he brought me back. I could stop the talk there because that illustrates everything that I think is so valuable in our institution. There is a fundamental openness, willingness to help, and to encourage people to pursue their dreams. Sometimes it works better, sometimes it doesn't, but Jim is certainly an example of that, and I'm very grateful for that. In fact, everything that I've done, I owe it to Jim, I owe it to my dad, as you'll see in a moment. He was a TB specialist, and to Dr. Stefan Grybowski, who was one of the champions of TB control in North America, particularly among the northern populations in this country. In any case, I arrived in 1981 to St. Paul's. I didn't know really what I was doing. And surprise, surprise, around the same time, HIV was arriving in North America. Trust me, through different means, but nonetheless, at the same time. You see here the United States statistics showing that death from HIV in men ages 25 to 44 very rapidly reach epidemic proportions, something that you'll see shortly also happened at St. Paul's. As I said, I was a respiratory doctor those days, and as Patty will remember, I started working in the clinical program and then in respiratory medicine. Since I was the youngest member of the team, I was systematically sent to the emergency to look after people with a very rare pneumonia called pneumocystis pneumonia. Like everything else in life, we didn't know much about it, but the more you do something, the more you like it. We got better at it, and eventually we contributed to finding ways to prevent it, to treat it, and to eliminate pneumocystis pneumonia. To our frustration, having done that, people with HIV will go on to die from other complications. And so I reached a critical point in my life at that time. I had to decide, would I go and continue doing respiratory medicine or reshape my focus to look after people with HIV and see if we could find a solution to this problem. And to the dismay of some of my senior colleagues, I abandoned respiratory medicine and I decided to pursue a career on the development of antiretroviral therapy. It was not a very smart move at the time, at least perceived by some, because there was only one antiretroviral medication available for research, ACT, which, as you remember, in 1986 was the first treatment for HIV. It was very controversial. It didn't work very well. It was toxic. But we pursued the research led by our group here at St. Paul's under John Rudy's leadership. And by a few years later, 1995 to be precise, after 10 years of trial and error, we came up with a strategy of combining antiretroviral drugs, including ACT, to control the replication of the virus. On the yellow panel on the top, you see the clinical trial that I had the privilege of leading internationally. On the panel at the bottom of the white is an American trial using different combinations of drugs, structurally different as well. Both at the same time concluded that if you use triple therapy, you could actually shut down replication of the virus. That would be the flatter line that you see down there, while using two drugs would allow the virus to come back very quickly, develop resistance, and everything would fall apart. Notice that not from those trials, but subsequent studies show that 6 months on highly active antiretroviral therapy, which is the name that we coined for this treatment, remarkably changed the clinical outlook of patients infected with HIV. The child on your left was symptomatic with AIDS, basically dying, and you see in 6 months that individual is basically back to normal. This is something that we have now reproduced innumerable times. We had the privilege at the time of being the lead for the organization of the International AIDS Conference that it was scheduled to take place in Vancouver in 1996. And so since we became aware of these very preliminary results, we made an executive decision, if you want, and we decided to toss the program out, start over again, and within a couple of months, we reconfigured the program So we transformed the Vancouver conference into the formal launching of highly active antiretroviral therapy to the world. This was a transcendental event. The paint that you see here is an iconic figure that it has been now linked forever with the launch on the birth of highly active antiretroviral therapy. It's a paint from my patient, Joe Average, who still today is healthy with living with HIV, despite the fact that in 1996 he already had multiple drug-resistant virus, something that in the absence of highly active antiretroviral therapy would have been lethal within a matter of weeks or months. And as you can see here, death per 1,000 dropped very quickly upon implementation of a free antiretroviral therapy program in British Columbia, and life expectancy started to improve very quickly. In fact, today, a 20-year-old person infected with HIV who engages on treatment immediately is expected to have a near normal longevity, free of AIDS, and eventually, as I'll show you in a moment, as pretty much as normal as your life is expected to be at age 20. Now, there is one important caveat to that slide. That's the impact of highly active antiretroviral therapy among people who were engaged on treatment. And that engaged in care is a key word that we very quickly discovered was a major limiting factor in terms of making the success of the treatment in the laboratory, in the clinic, a reality for everybody. And so very quickly in the mid-90s, we made an important priority of our program to bring the services to the people. In other words, to try to understand what the access barriers were, as Fiona pointed out, not the access barriers, physical access barriers that we are able to simply identify, but actually what they perceive as the barriers that we needed to bring down. And that led us to do a lot of work in terms of simplifying treatments, simplifying access, working with communities most affected, including developing harm reduction programs. I'm not going to talk about anything in that regard, simply to say that we succeeded in all those accounts, and that's the reason why our results have been as I will show you in a minute. Importantly, shortly after we started treating people with HIV with this treatment, the question became whether or not the treatment would contribute to stopping the epidemic going forward. The United Nations at the time had documentation from their own programs suggesting that even if treatment was partially effective at reducing transmission, the potential behavioral disinhibition that these could be associated with could lead to an expansion of the epidemic. We, on the other hand, had field data, as you see here, showing that HIV-infected people were not dying as they were prior to 1996. Namely, the number of people living with HIV in British Columbia was expanding, and yet the number of new infections was declining, while the number of cases of syphilis was expanding. In other words, sexual behavior could not account for the change in trends that we were seeing. This is at the time in which there was a new epidemic, explosive epidemic, particularly in the downtown east side, among injection drug users. So this did not make any sense. More people living with HIV, more IV use becoming infected, and yet overall transmission in the province going down. We looked into this, we modeled it, and we concluded that in order to explain these results, treatment for HIV would have to be at least 90% effective on reducing transmission. We did a fair bit of work on that and eventually published a fairly controversial paper in The Lancet, arguing that if we were to treat everybody infected with HIV in a given jurisdiction, you would be able to stop morbidity from AIDS, you would be able to stop mortality from AIDS, and you, secondarily, for no further investment, you could stop HIV transmission, and therefore you could see a roadmap towards the end of the epidemic. These results were not particularly well received by the scientific community. It was regarded as highly controversial. Interestingly, on the spot, we received a strong support by a variety of very high key figures who did not have the same kind of conflict of interest that many of our scientific colleagues would have. And that included Stephen Lewis. Stephen Lewis, many of you are familiar with him, is a leader in human rights in this country. day that we made the presentation, President Clinton requested to meet with me, and since then has been a champion of this strategy. And equally important, my good friend, Dr. Nora Volkov, came and rallied behind us and committed her support to our initiative. Nora Volkov was and continues to be the director of the National Institute of Health Institute for Drug Abuse. She funds the largest international program of research in the area of injection drug use or other substance use. And she saw in this strategy an opportunity to increase the relevance of treatment for people who use drugs, which would be of interest to her program. And so a real synergy emerged from this. This is a complex slide, but it's basically the history of the HIV epidemic from 1996 to 2017. I will not talk about PrEP specifically. Fiona already addressed the issue of pre-exposure prophylaxis. Our provincially funded PrEP program became available on January 1st, 2018. Therefore, this data is relatively free of the contamination of the impact of PrEP. This is all about treatment as prevention. And in brief, what it shows, let me use my pointer. What you see here is basically the number of people that started treatment in 1995-96. Very quickly, this takes off. There was a period of time where people had mixed feelings regarding the treatment because it was cumbersome, it was toxic, and so on and so forth. But as the drugs got better and our understanding of how to monitor it became more sophisticated, we were able to expand the number of people in treatment. The Premier at the time, Gordon Campbell, rallied behind our proposal in the early 2000s, and so we've been able to expand this program steadily ever since through any and every leadership in Victoria. All stripes of the government have been very supportive. And what you can see here is the number of people increasingly embarking on antiretroviral therapy to the point that today we have in excess of 8,000 people on treatment, which is pretty much about 80% of those infected with HIV in the province. You see here the number of HIV new infections declining on the red. This relationship between the number of people on treatment and the number of people being newly diagnosed follows a very nice mathematical equation, and it's actually quite reassuring. For every 1% we increase the number of people on treatment, we decrease 1% the number of people being newly diagnosed. The reason why I highlight that equation for you is because this study has now been reproduced in KwaZulu-Natal by our colleagues in Harvard in collaboration with South African researchers, and they have shown that this relationship is exactly the same in South Africa as it is in Vancouver in British Columbia, meaning that this works in the north, it works in the south, it works everywhere. What you see also is that we are testing more, so these are the number of people that are being tested, which argues that this decline in the number of new infections is for real. It really reflects the decline of new cases and not an artifact of under-testing. You see on the yellow the number of HIV infections among injection drug users. And you see that in the last decade, we have virtually eliminated HIV transmission in the injection drug using community. The IDU epidemic in this city and in this province is virtually under control. And the reason for that is very simple. We have been leaders in the implementation of harm reduction programs. And treatment as prevention is synergistic with harm reduction. In other words, and this is particularly relevant to my friends down south, you will not be able to control the HIV epidemic if you don't embrace harm reduction, whether you like it or not. Finally, you see on the green the epidemic among men who have sex with men in British Columbia. And yes, we have had less success, if you want, from an epidemiological perspective, in controlling the epidemic of HIV among men who have sex with men. The answer for that is very simple. While we have a synergistic tool to control the epidemic in injection drug users, which is harm reduction, until very recently, until PrEP became available, we only had really 1/3 thing that was highly effective in that setting, which was treatment, and in order to afford high level of protection to a man who has sex with men, you need to cover the whole network of partners that they may have likely, and that is very difficult to achieve. So what we see here is that there is a decline in the number of new MSM cases, but it's not of the same order of magnitude that we see for IDUs. Having said that, please notice that here on the dark blue, you have the cases of syphilis in the province of British Columbia. They are going through the roof, and in fact, they have continued to increase significantly over the last year. And statistically, they are predominantly among MSM, men who have sex with men, and they are statistically more frequent among people with HIV. What that tells you is that this, in contrast to that, is extremely significant. I alluded to the fact that we are seeing the end of the AIDS epidemic in British Columbia. I suspect that the previous slide illustrates that for you. There is a further piece of data that I want to share with you, which pertains to the age of the cohort of people infected with HIV in British Columbia. And not surprisingly, given that we have less infections coming in and people are growing older, as you can see here, the median age over the last several years, from 96 to 2017, has grown from around under 40 to over 50, indicating that that's a cohort that is evolving with time, like I am and all of us, and therefore, not surprisingly, while AIDS death on the light color here is declining significantly, what you see is an expansion of the non-AIDS death in people who are dying from the same things that you and me were going to die from. What that means is we have normalized the life of people living with HIV to the best extent possible, and in doing so, we are controlling the epidemic at the same time. So the bottom line regarding this epidemic in British Columbia is that we have new HIV infections despite increasing sexually transmitted infections. We have remarkably low AIDS-related morbidity and mortality. We have an aging cohort effect with increasing non-AIDS mortality. I have not addressed the issue of the fact that the medications are increasingly becoming generic, and so we are saving money on that front as well. And that's the reason why the ministry has been willing to allow us to expand our program within the same funding envelope to now accommodate pre-exposure prophylaxis. And while I would say that I would not discuss PrEP yet, because we're only in the first year and we don't have the full piece of data that I would like to share with you, let me share with you briefly some of the preliminary data that we have from Vancouver Coastal. Vancouver Coastal typically was diagnosing at least 110 new cases per year. In the last year, there was a greater than 30% reduction on the number of new cases. More importantly, we do phylogenetic fingerprinting, that is to say, we fingerprint the virus for every person infected in the province of British Columbia. And in doing so, we can identify clusters of transmission. The majority of the people that were becoming infected in British Columbia until 2017 were as part of clusters. In the last year, since PrEP came on board, we have found only 3 individuals infected through clusters out of 70 people that were infected over that year. We are virtually seeing the end of the epidemic thanks to the combination of treatment and prevention, harm reduction, and PrEP in British Columbia. Stay posted. Those results hopefully will mature within the next 6 to 12 months. The other thing that I did not allude to that was incredibly important, not so much for British Columbia, but for the rest of the world, is the fact that highly active antiretroviral therapy is 100% effective at protecting a child from becoming infected from an infected mother. In other words, with treatment as prevention, by offering treatment to everyone infected with HIV, we don't need extra additional programs. We simplify the programs. If you are HIV positive, you need to be on treatment. We make it available to you for free. We make the laboratory available to you also for free, and therefore we can prevent morbidity, mortality, transmission, including transmission from mother to child in the case of a pregnancy. British Columbia has not had a child born domestically with HIV infection over the last 20 years. Be aware that this is not the case for the rest of the country. There are children being born with HIV in this country as we speak, which is unacceptable. Now, I know perhaps some of you, maybe not you, but some would argue that, well, Julio, this is a very good idea, but you know what? There are so many pressures in the health system, I'm not sure we can afford this. And my answer to that is you cannot afford not affording this. It would be stupid, to say the least, to save money by promoting HIV infection. And the data is clear. What it shows is that, for example, in this case, if you model the impact of expanding antiretroviral therapy in South Africa, this is work done by Ruben Granich and Brian Williams, based on our treatment and prevention model. They were based on the WHO back in the day. And what you see here is that as you expand antiretroviral therapy, ultimately in the blue, to testing everybody and offering immediate treatment to everybody, treatment as prevention, you have the opportunity to save millions of lives. Not just millions of lives, but you protect the families, you protect the society, you protect the children. So one single strategy does it all for you. But importantly, at the same time, what you see in the other slide, the right-hand side of the slide, is that while treating more costs more, the spike is very short-lasted, I often say within a political mandate, and in doing that, rapidly it becomes cost-saving to the point that in a matter of 30 to 40 years, you actually make money out of this strategy. And why is that? Because you prevent new infections. And preventing new infections prevent further new infections down the road. So the return on the investment of this strategy is exponentially greater the better you apply the strategy. And I'm happy to tell you that British Columbia is currently somewhere around here. We are saving money in our program, and that allows us to reinvest on better refinements to ensure that we continue to work towards a rapid end of the epidemic in the province of British Columbia. And in doing so, rightly so, I said, we feel that we have an obligation to bring this to the rest of the world. And so we've been working very closely with international organizations, in particular the United Nations, developing new goals for the expansion of antiretroviral therapy, not just in the north, but also in the south of the world. And it's a long story, but suffice to say that I was challenged in 2014 to come up with a new goal for the rollout of antiretroviral therapy that would be informed on the work that we had done in British Columbia to control HIV. And we call that the new ambitious treatment target, which had a stated goal of writing the final chapter of the AIDS epidemic. We defined the final chapter of the AIDS epidemic as a strategy to decrease the morbidity, mortality, and transmission of HIV and AIDS by 90%, all of them, by 2030. And using our own data, we came up with the notion that if by 2020, countries around the world were to commit to diagnose at least 90% of people living with HIV, and if they were to commit to have at least 90% of those on treatment, and further to commit to have at least 90% of them virologically suppressed, in other words, adequately treated, by 2030, we would have a 90% decrease in the burden of disease in terms of mortality, morbidity, and transmission. And after we developed that proposal, we sent it to the United Nations. They sent it to New York to an independent group, Storvedall, to verify our assumptions. And clearly they came up with the notion that if we do this, we would decrease AIDS death by 90% by 2030, and we would decrease new infections by 90% by 2030. And on the basis of all of this evidence and other evidence that is available elsewhere that I have no time to discuss for you, both UNAIDS and WHO in 2015, funny enough, at the International AIDS Conference that we had the pleasure of chairing here in Vancouver in 2015, they both announced that treatment and prevention and the 90-90-90 would be the new goal for the world based on the expansion of testing and treatment for all infected with HIV, and also the inclusion of pre-exposure prophylaxis for people who were at risk of HIV infection. We took it to the General Assembly of the United Nations. This was ratified by all signatory countries. So today, the 90-90-90 and treatment and prevention are part of the SDGs. We won the battle, normatively speaking, we won the battle politically speaking at the global level, But I hate to tell you, in 2015, Stephen Harper's administration refused to come with me to the United Nations to celebrate this development. It wasn't until a bit later that we were able to get to the Pope, and we got good old Francis to sign on to the strategy. I was delighted to be there for that event. He actually put it in writing for us, and this was read at the opening of the 2015 conference, which was very well received. It was critical, by the way, to have the blessing of the church, not just because I'm a good old RC, but actually because we needed that in order to overcome some of the prejudices in some areas of the world where people felt that it was more cost effective to look after orphans than actually protecting the family from having orphans. In October 2015, Justin Trudeau, in the middle of the campaign, and I remind you at that time he was the third in popularity, came to our offices. He was fully debriefed, and he agreed to endorse the strategy. Most people laughed at me, but eventually Justin became the Prime Minister. On October the 8th, he wrote us an unsolicited letter committing to that. Most people say, well, it's easy to commit when you're not going to form government, but he did, and within a month of forming government, December 1st of that year, he actually formally endorsed the 1990. 10 years fighting with the Harper government did not get us anywhere. Trudeau did it within a month. The economies of all papers has been strongly behind this work now for a number of years. And in fact, this is a cover from the economies about close to a decade ago, asking whether or not this could be the beginning of the end of AIDS. The answer is yes. This is the beginning of the end of AIDS. But there is one caveat, and the caveat is that we need to get on with the work if we're going to get there, because just talking about it is not going to do it. And so I am here today to recruit your support, to talk to everybody you can, to remind them that yes, we can, but we won't, unless we make the investment that needs to be made. And this is a couple of slides that illustrate that. What you see here is that there has been slow progress in the control of HIV/AIDS. The number of AIDS-related deaths by 2020 should be here if we're going to meet the treatment prevention 1990 target. We're currently proceeding along this line. There is no way we're going to be there unless we redouble our efforts. The number of new HIV infections are going down, yes, but this is not satisfactory. We should be here by 2020 if we're going to meet our 2030 ultimate goal. We are not going to do it simply because the political leadership, they like to talk, but they don't like to open the wallets. And that is illustrated here. The resources available in low and middle income countries to fight HIV and AIDS were increasing steadily, funny enough, until 2008, when treatment prevention became a reality. And with the excuse of the recession, that stopped and it never resumed. So we have a problem. We need your voices to rally behind our voices to demand that this be done. We met with the Federal Minister of Health, Jeanette Petitpas-Taylor. In fact, Fiona was there last week when the minister visited our offices, and the Honorable Hedy Fry, who represents our riding here in Vancouver, and they were both very impressed and very supportive for this work going forward, not just here, but internationally. And we have requested from them a 30% increase on the Canadian contribution to the Global Fund refinancing, which is happening as we speak. That would bring up our contribution to $1 billion, which is what we need to do if we're going to set an example for the rest of the world how to move this agenda forward. So on that note, I leave you with an encouraging message. Yes, we can stop HIV and AIDS. We will in British Columbia before my time is over, unless something happens, of course. But in the meantime, we need to recognize that this is not happening elsewhere. It's not happening in Canada. It's not happening in North America. And it's not happening around the world. There are selected jurisdictions that are effectively pursuing this agenda. They are few and far apart. We need public outcry if this is going to happen. Thank you very much.